Hello, everyone, and welcome to Taking the Call, a national conference exploring innovative community responder models presented by the Council of Governments Justice Center in partnership with the University of Cincinnati and with the support of the Bureau of Justice Assistance. I'm Dr. Aisha Delaney Brumsey, and I'm the Director of the Behavioral Health Division at the Council of State Governments Justice Center. The CSG Justice Center, as we're called, is a nonpartisan, nonprofit organization working with leaders from all three branches of government to increase public safety and strengthen communities. Today, nearly 3,000 of you registered from all 50 states and internationally. Welcome to each and every one of you. We also have 40 teams participating, with representatives from behavioral health, law enforcement, 911 leadership, and other community leaders. At the end of each day of the conference, these teams are dedicating time to work together and plan new or expand on existing crisis services in their communities. To all of our teams, I hope this time together is inspiring and productive. The sheer number of you here today is not trivial. It is a reflection of the commitment that so many have made to improve our crisis systems in order to promote health and well-being and build trust between communities and government. Coming together to engage deeply through these 2 days can be a step towards transforming our systems of care and justice. We have an incredible slate of speakers lined up for you, and we're eager to get started. But before we do, a few housekeeping notes. First, if you have any technical challenges, the team at Beacon Live is ready to help you. Here in the platform, you can reach out through the Tech tab on your screen and request support. If you have trouble accessing the platform, the help desk phone number is available on the conference website. Second, we encourage your participation throughout the conference. You can do this in 2 ways. Here, you can submit questions using the Q&A window on your screen. We may not get to all of your questions, but we'll certainly do our best. You can also join the discussion on Twitter using the hashtag #TakingTheCall. This opening session, All Partners to the Table, Leaders Advancing Crisis System Reforms, has an exciting group of speakers and panelists discussing how communities are working across behavioral health and criminal justice to build more effective crisis systems. And to start us off, I'd like to welcome Director Kristen Mahoney. She is the Acting Director of the Bureau of Justice Assistance within the Office of Justice Programs. She brings deep expertise creating criminal justice policies, programming, and technical assistance for state, local, and tribal communities. In 2016, Director Mahoney was recognized for her work developing the Violence Reduction Network, now the National Public Safety Partnership, and was awarded the Presidential Rank Award of Meritorious Executive by President Barack Obama. Director Mahoney, I'm pleased to turn it over to you.
Thank you very much, Dr. Delaney Brumsey. It is wonderful to join you all today, and I am so excited to help open this conference. I just want to quickly thank you, Aisha, and our outstanding partners at the Council of State Governments Justice Center and the University of Cincinnati, not to mention my Justice Department colleagues and the amazing staff at our Bureau of Justice Assistance, Cornelia Sigworth, Elizabeth Wolf, Maria Fryer, and Michelle Martin. You all need to take a virtual bow. This is going to be fantastic. I'm truly grateful for all of the hard work that has gone into planning this event, and I'm looking forward to a fantastic 2 days of information and conversation. So to set us in motion, I have the distinct great privilege of introducing our first 2 keynote speakers. First, we will have the pleasure of hearing from our Attorney General. Merrick Garland was nominated by President Biden in January and confirmed by the Senate on March 10th to be the 86th United States Attorney General. Before his confirmation, he served as a judge of the United States Court of Appeals for the District of Columbia. He was Chief Judge from 2013 to 2020. He has spent a substantial part of his professional life at the Department of Justice serving under 5 attorneys general. He now leads an agency dedicated to upholding the rule of law, keeping our country safe, and protecting the civil rights of Americans. Following the Attorney General, we will hear from the Associate Attorney General, Vanita Gupta. Ms. Gupta is the third highest ranking official at the Department of Justice, and she oversees multiple litigating divisions and the grant-making components of the department. Before her confirmation, she served as the President and Chief Executive Officer of the Leadership Conference on Civil and Human Rights, the nation's oldest and largest coalition of nonpartisan civil rights organizations. She also served as the acting Assistant Attorney General of the Justice Department's Civil Rights Division during the Obama administration. The Attorney General and the Associate Attorney General took the time to record the remarks to set the tone for this conference. We are honored to have them both join us today, and we'll now hear from them in succession. Thank you.
Hello, and welcome to the Taking the Call National Conference. It is a pleasure to be part of this new event focused on a crucial topic. I want to thank our Office of Justice Programs Bureau of Justice Assistance, the Council of State Governments Justice Center, and the University of Cincinnati for organizing this event. This convening addresses some of the most pressing issues we face as a country. Our society is turning to law enforcement to address a wide array of social problems. Too often, police officers are the first ones called when someone is experiencing a mental health crisis. In many jurisdictions, these calls seem to increase every year, and they often lead to challenging interactions. They take longer to resolve and can create unnecessary physical confrontations. Even after situations are controlled, responding officers are limited in where they can transport individuals experiencing a crisis. These realities raise difficult and urgent questions. When a call is placed to 911, how can we improve the response? How do those responses protect public safety, ensure public health, and build trust between communities and law enforcement? How can our public safety and health systems work in concert to support individuals in crisis? I am glad that we have gathered to address these challenging questions. I am also proud that the Justice Department is supporting efforts to build partnerships between law enforcement and behavioral health systems. Throughout our Justice and Mental Health Collaboration Program, the Department provides grants to help communities implement new responses to 911 calls. This includes embedding clinicians in 911 call centers, supporting co-responder models, and much more. This year, the Bureau of Justice Assistance released a new program called Connect and Protect. This behavioral health response program aims to build and implement collaboration between law enforcement and mental health providers. Among other things, this program supports crisis intervention teams and public safety partnerships with social service and community providers. The Justice Department also published a police mental health collaboration toolkit and stood up 14 law enforcement mental health learning sites. The toolkit helps communities implement law enforcement and behavioral health best practices. The learning sites help communities improve outcomes when law enforcement encounters people with mental health and substance abuse needs. This includes promoting strategies from 24/7 crisis stabilization units in urban settings to rapid mobile crisis response units in rural communities. In addition, the Justice Department will offer upcoming training programs to enhance police officers' ability to engage with people with behavioral health issues or developmental disabilities. I have been Attorney General for just over half a year. During that time, I have met with a diverse group of stakeholders and experts. It is clear to me that there is wide agreement on the need to coordinate law enforcement and behavioral health approaches to crisis response. At the Justice Department, we know that our law enforcement partners share this view. We are grateful for their support. We are also thankful for the support and attention of our colleagues at the Department of Health and Human Services, the Department of Housing and Urban Development, and so many others who are deeply committed to this work. Sharing best practices across agencies, areas of expertise, and all levels of government will help everyone improve responses to crisis situations. That is the spirit driving this important convening. We hope that this gathering will help you learn about crisis system innovations that you can take back to your communities. Together, we can work toward more effectively combining health and safety systems so that everyone involved in a crisis situation experiences better outcomes. Thank you for joining us in this effort.
I want to echo the Attorney General's thanks to the Bureau of Justice Assistance, the Council of State Governments Justice Center, and the University of Cincinnati for putting together an extraordinary agenda for this convening. Participants in this conference span the spectrum of experts, including law enforcement leaders, judges, government officials, health professionals, individuals with mental illness, researchers, advocates, and so many more. Your diversity of experiences is critical. Addressing the issues faced by people with mental illness requires a holistic approach that relies on the cross-sectional expertise that you all bring to this conference. The Attorney General, Deputy Attorney General, and I have had numerous conversations about ways in which the department, in coordination with other agencies, can ensure that whenever possible, those who need mental health treatment can get access to services before getting involved or further involved with the juvenile and criminal justice systems. So I'm truly excited that you all have joined us for the next 2 days to address this important issue. We've come together because we share a commitment to some simple core values. First, those in crisis must be treated with compassion, respect, and dignity. Second, building trust between law enforcement and those they serve is a cornerstone of maintaining public safety. Third, real comprehensive reform in how we treat people with mental illness will make policing safer and the justice system more effective. Nearly 3 decades ago in Memphis, Tennessee, the fatal shooting of Joseph DeWayne Robinson highlighted the need to change the law enforcement response to people in crisis. In the wake of that tragedy, the first crisis intervention team program was developed. And over the years, thousands of officers have been trained in CIT to effectively interact with people with mental illness, de-escalate crises, reduce the use of force by officers, and connect people with treatment instead of the criminal justice system. Today, we're at another watershed moment. 2 historic events coincided in 2020. First, the tragic death of George Floyd and the widespread community mobilization that followed renewed a necessary and urgent national conversation about community trust, equal justice, and policing. Second, the COVID-19 pandemic greatly strained our public health, employment, and housing systems and exacerbated our mental health crisis. These events have re-energized efforts to change how we treat people experiencing a mental health emergency. Training officers how to respond to people in crisis remains as important as ever. But we now recognize that placing the responsibility entirely on law enforcement is inadequate. Other sectors of our communities, behavioral health professionals, supportive housing providers, employment agencies, community leaders, and others, all have essential roles to play in keeping our communities safe and providing people with mental illness and their families with necessary support. Indeed, our law enforcement partners have repeatedly told us that they cannot alone shoulder the responsibility of addressing the needs of people in crisis, and that change is needed for them and the communities they serve. Officers have difficult and at times very dangerous jobs. So much honorable work done by law enforcement professionals does not get enough attention, and we commend such professionals and their families for their daily sacrifices. The stress and trauma of these jobs can take a heavy, heavy toll. We shouldn't add to their burden by requiring them to address a wide array of social problems, problems that cannot and should not be solved by the criminal justice system alone. Law enforcement is joined by many others in calling for greater support for people with mental health issues. Since the start of my tenure as Associate Attorney General, I've heard from prosecutors, judges, sheriffs, and advocates, including many of you. And what I've heard is an overwhelming consensus that our society must support behavioral health programs so that we can treat, not jail, those in crisis where that is possible. We must commit to expanding options because we have a collective responsibility to care for those who need treatment. And we simply cannot arrest or incarcerate our way out of the challenges presented by untreated mental illness, co-occurring substance use, homelessness, and poverty. We also cannot sustain a system in which jails and prisons are the largest mental health providers for people with severe mental illness in cities and counties across this nation. We know that once incarcerated, people who have severe mental illness are likely to spend more time in prison than those who don't. And when released without treatment, they are likely to get arrested again. By providing community-based treatment to people with mental illness, we can break the cycle of arrest and incarceration for the most vulnerable members of our society. We may also save lives by expanding options. According to the Washington Post, almost a quarter of all fatal officer-involved shootings since 2015 have involved people with mental health issues. Although no single program or service will prevent every tragedy, we know that a comprehensive approach that includes community-based mental health care is integral to effective solutions. I am heartened to see that so many communities have engaged in concerted efforts to expand diversion programs to ensure that people with mental illness are connected to community-based treatment and are kept out of the criminal justice system altogether where possible. I'm also excited to see the many innovative approaches for answering the calls when they do occur. Many communities have evolved from relying solely on law enforcement to collaborating among law enforcement, trained health professionals, government leaders, and community members, and creating new programs that best serve the needs of the community. These innovations include programs modeled on the CAHOOTS program, where health professionals respond to certain types of calls, co-responder programs which pair health professionals and police officers, case management for high utilizers, and many more. No single model can be prescribed for every jurisdiction, but we do know that active engagement with the community and government leaders is essential for building programs that save lives, protect people with mental illness, and make policing safer and more effective. As states and localities continue to develop these innovative programs, the department stands ready to support and amplify their efforts. We recognize that this will require a whole of government approach, and we look forward to engaging our partners across the federal government to coordinate resources in public health, jobs, housing, and the justice system. As the Attorney General noted, the Department of Justice has long supported this work. BJA's Justice and Mental Health Collaboration Program has been a key partner in establishing a number of successful programs. I want to emphasize that JMHCP funds can be used for a wide array of programs involving people with behavioral health needs, including first responder programs, community courts, crisis stabilization units, training for public safety and mental health providers, and programs that support intergovernmental cooperation between state and local governments. We also know that there are challenges to establishing and maintaining these programs, and we're proud of our efforts to provide technical assistance, training, and resources to those in the field. Just 2 weeks ago, the department's COPS Office for Community-Oriented Policing Services announced $33 million in funding under the Community Policing Development Program to provide technical assistance to advance community policing programs, including crisis intervention team partnerships between law enforcement and mental and behavioral health professionals. The COPS Office's CRITEC Collaborative Reform Initiative also provides technical assistance to state, local, territorial, and tribal law enforcement agencies. And the Center for Justice and Mental Health Partnerships offers free consultation to any community that requests help to support their efforts in diverting people away from the criminal justice system and safely connecting them to treatment and supports. As more and more programs are established, the department can engage in research and evaluation and identify those innovations that prove effective and consider ways in which such programs can be scaled to other jurisdictions. In addition, the Department's Civil Rights Division uses its enforcement authority to protect the rights of people with mental illness by promoting a community-based approach where appropriate under the circumstances. Supporting law enforcement wellness is also a really important part of this process. Just last week at a roundtable with state and local law enforcement, the Deputy Attorney General and I announced $7 million in COPS Office grants under the Law Enforcement Mental Health and Wellness Act program to improve the access to mental health and wellness services for law enforcement. These are just a few of the resources that we have available, and I know you will be hearing more about them tomorrow. As the convening begins, I want to emphasize that I see this conference as a new chapter of our conversation. I see tremendous energy and momentum among local, state, and federal partners ready to address these complex issues. And I see a common vision, whether it's police officers who interact with people on the streets, sheriffs responsible for managing jails, judges whose dockets are filled with people cycling in and out and back in for low-level offenses, community members who want their loved ones to be healthy. We all want to treat people with mental illness with dignity. We all want to reduce unnecessary arrests and incarceration. We all want to support and strengthen officer wellness. We all want to promote public safety, and we all want to build trust between police and the communities that they serve. Thank you for your leadership, your vision, your innovation as we forge forward together in pursuit of equal justice and safe communities.
Thank you very much, Attorney General Garland, Associate Attorney General Gupta, and Director Mahoney. Your remarks have beautifully set the stage for today's conversation. And as you noted, we launched this conference because we heard that communities are asking themselves tough questions. How do we move away from a system that is too reliant on law enforcement to address complex health and social service needs? How do we answer calls for racial justice and health equity? How do we build systems that compassionately respond to people experiencing illness and trauma? For years, communities have been working to answer those questions. And one part of that answer for some is implementing community responder programs. Because people use different words to describe these types of initiatives, I wanted to explain how we're using that term here at this conference. A community responder program is a mobile response unit that deploys behavioral health professionals to 911 and other urgent calls for service. The behavioral health professionals responding to these calls might be social workers, peers, community health workers, or others. Sometimes these professionals are coupled with emergency medical technicians or other physical health professionals. These teams can respond to a range of calls, such as when someone is in a mental health crisis, when neighbors are having a dispute, when a person is overdosing or in need of emergency housing, among other concerns. These initiatives can differ from place to place, but the overall goal is often the same. Community responder programs aim to reduce unnecessary law enforcement contact while also connecting people to supports that improve long-term well-being. So today, you will hear about community responder programs, but you will also hear about how communities are working to build effective crisis systems more broadly. And this is important because we know that community responder programs, like all individual interventions, work best when they are part of a comprehensive system of care. Systems that aim to prevent crises before they happen and support people in the aftermath of a crisis. Systems that treat people with dignity and respect. Systems that center and respond to the needs of people with mental health or substance use conditions, people of color, people in poverty, and all of us. As we continue to cope with the ongoing loss of life and emotional toll of the COVID-19 pandemic, this work has become all the more essential. And so with that, I would like to welcome our panelists who have been doing amazing work in their communities to share their experiences with all of us today. And I am joined by Tim Black, who is the Director of Consulting at Whiteberg Clinic's Crisis Assistance Helping Out on the Streets, or CAHOOTS program in Eugene, Oregon. With a background in runaway and homeless youth, harm reduction and street outreach, Mr. Black began working for CAHOOTS as a crisis intervention worker in 2010 before moving into an administrative role. Dr. Deborah Peinels is the Medical Director for Behavioral Health and Forensic Programs at the Michigan Department of Health and Human Services. She's also the Director of Program in Psychiatry and Law and Ethics and Clinical Professor of Psychiatry at the University of Michigan Medical School and Clinical Adjunct Professor at the University of Michigan Law School. Chief Gordon Ramsey has served as the Chief of Wichita, Kansas Police Department since 2016. He's a past president of the Minnesota Chiefs of Police Association and served as the General Chair of the International Association of Chiefs of Police Midsize Agency Division, and he is currently the Central Region Representative for the Major City Chiefs Association. Mr. Akil Shirels is the Chairman of the Board for the Newark Community Street Team and the co-founder and leader of the community-based Public Safety Collective. He is also the Senior Advisor to Hyphen for the White House Community Violence Intervention Collaborative. Thank you all for being with us here today. So I want to move into our conversation. So first, I'd like to turn to you, Dr. Peinels. Could you begin by setting the stage a little bit? You've done a great deal to support implementation and improvements to crisis systems in Michigan as well as nationally. So could you tell us why it's so important now when there's a lot of issues competing for our attention to keep advancing crisis system reforms?
Sure. Well, first of all, I just want to thank you at CSG for inviting me to participate in this important discussion, and especially our federal leaders for driving this conversation to the point where we are able to convene. So special kudos to them for hosting this conference. I came to this work as a psychiatrist who worked in various settings in clinical, where patients arrived, emergency departments. I've worked in jails, I've worked at court clinics, across the landscape. And I saw too many people with mental health and substance use disorders who were caught in the criminal justice system. I went on to become a forensic psychiatrist and did plenty of evaluations for the courts and helped with specialty courts. But these issues just come up too much. And we see that there's differential representation for communities of color that get caught in the intersection of mental illness and the justice system. And we really need to find ways to serve them and serve them in a way that's respectful and caring for their well-being. And now we're in this critical moment. And I think, as the Attorney General and the Associate Attorney General said, there's many factors that have come together, and there's a confluence of variables that make this the right moment and a critical moment to get it right. For example, we're seeing alarming rates of anxiety, depression, substance use across the country in the wake of COVID-19. Some of those problems were happening even before COVID-19, like the suicide crisis in the United States. And despite concerted efforts, the opioid overdose continues to rise. The rates of death continue to go up. We see too many youth waiting in emergency departments for psychiatric care. And, we're seeing a lot of questions arising about if we are going to engage in diversion into a continuum of care in the community, what is that continuum of care going to look like? And who's going to respond to the calls, which is why I love the title of this conference. And so there's a lot of discussion happening in every circle. I don't think a day goes by where this crisis continuum isn't brought up. And it's really an interesting moment because we also have on the table the passage of 988. 988 became the 3-digit number approved by the FCC in July of 2020. And now there's tons of planning going on to look at what 988 is going to be as a behavioral health response. There's investment of new financial resources into crisis systems, with many communities, as we heard about, expanding those collaborative, innovative efforts to think about going beyond CIT, beyond co-response, and really thinking about all sorts of ways that a community can build the right system to respond to its citizens or its residents in the best way possible. We're trying to build out that mobile crisis response, and that response is going to have to be able to deal with the challenges of COVID-19 and what that's going to look like going forward, as well as the rising rates of suicidal ideation. We have to think about what people are facing in terms of economic strains and housing challenges that people are facing. And because of that, the health systems will also be further challenged. And so no one entity can tackle this by themselves. These partnerships become really pivotal to helping people navigate and get connected to the supports that they need. So how 988 dovetails with 911, how the hospital systems, the emergency departments, the crisis stabilization units, the law enforcement response all come together is all being built as from lessons learned and really becoming innovative and driving change to meet the needs of our society. We have to get to a place where anyone can get the services that they need, and then beyond the crisis, get linked to what we call the vital continuum of supports, whatever that looks like, because we know that after a behavioral health crisis, there's more that might be needed to help support that individual to achieve success in their lives.
Thank you, Dr. Peinels. I think that's helpful for you to be able to outline for us what that vital continuum looks like and why it's so important now and why we have some of the a real opportunity now to build that out. And, so I think that actually brings me to Mr. Black. Mr. Black, as Dr. Peinels noted, we're in this moment where it's crucial to, and where a lot of communities are working to reform their crisis response systems. And for many, a key part of that work is to think differently about who responds to calls for people in mental health crisis or when someone is sleeping outside. And Eugene, Oregon answered that question in part by launching Cahoots. So for communities who are seeking to answer that question themselves, what would you recommend that they should consider?
I think the biggest thing that really needs to be taken into consideration is what the community itself is asking for. As I have this opportunity to engage with different cities, counties, states, as they're really exploring the potential to bring programming inspired by Cahoots to their area, the first question is, what is it that the folks that are being impacted by the lack of services, are telling you that they need? What is it that you're hearing from consumers in behavioral health, in recovery, in shelter settings? And then how can we take that community input and those needs and really build a program that can really respond in unique and nuanced ways to what that community is calling for?
That's great. That's great, Tim. Could you also flesh that out a little bit for us? Could you tell, for some of the speakers who might not have heard you talk before, a little bit about, what the Cahoots program is and how it responds to these calls for service?
Yeah, so Cahoots teams are dispatched by public safety. Here in Eugene and Springfield, our teams are out there responding to calls 24/7 based on requests that are coming in through 911 and the non-emergency line. What makes us a little bit different than what you might see in other communities is that Cahoots is operated by a federally qualified health center, the Whitebird Clinic. Rather than being city employees, our responders, our EMTs, and our crisis workers are part of the Whitebird Clinic organization. And that partnership has really allowed us to build community trust in a way that I don't think we would have if we were just another division of the city, public safety response system. Cahoots teams respond to crises that are stemming from not just mental health, but addiction, poverty, homelessness, and really are out there to facilitate interventions around anything, that's nonviolent and then that doesn't require that criminal enforcement approach. Because we have EMTs as part of our response, we're also able to do a lot of work around harm reduction, non-emergency medical care, really responding to that intersectionality between physical and behavioral health needs. And looking at our impact overall, our teams responded to over 20,000 calls for service last year. And so there's profound demand in our community, and arguably the same, if not larger, demand in cities across the U.S. who don't have similar programming yet.
Thank you so much, Mr. Black. I think taking what Dr. Peinels just said about that continuum of care, and then what you just said about how Cahoots responds to these calls, but also is kind of built into that continuum of care and how that is helping to respond to calls for reforming crisis systems. I'd like to actually bring up you, Chief Ramsey, and ask you the question about, from a law enforcement perspective, how are you and other law enforcement leaders responding to calls to reform crisis response? And what do you see as the role of law enforcement in this conversation, in this movement?
Well, over my 28 years in policing, I've really seen the mental health systems change to more community-based models. And ultimately what that has meant in many cases is an over-reliance on police to deal with mental health issues. And because so often of the mental health calls are funneled through 911, police are often the responders. And, I've seen cuts to mental health over the years where we used to have crisis centers, different hours and different resources that because of budget cuts are no longer available. So police adapted, and through the years, and as the problems have grown, we've recognized that we need to change how we respond. So we built a homeless outreach team with specially trained officers that focus on, getting people stabilized and working with our partners. Our officers are often bounced around when we do have people that are suffering from mental health crisis, particularly those that are violent in nature. You know, issues 20 some years ago, we began talking with ERs and detox facilities and other providers on how we can work better together, because everybody was getting annoyed with each other. You know, we're not the ones to deal with this or that. And so those conversations have evolved, and as a result, we have the homeless outreach team that is specialized in dealing with people that are in crisis and homeless and focus on getting people stabilized. Recently, we got a grant through BJA for housing stabilization workers that work with our homeless outreach team to keep people stabilized in their homes. You know, we've been trying many different ways to work around some of these issues. You'd be amazed at the number of 911 calls that we get for 10-year-olds that won't go to school, and a single mom needs help. And you know, 911 is the way to get an immediate response of a government employee to your house. So we got the state to fund a couple caseworkers that work with families out of the police department, that rather than sending police, these caseworkers go. And of course, the integrated care teams with a firefighter, a paramedic, a social worker, and an officer are responding and diverting a lot of cases from emergency rooms with significant savings as well as greater success rate. Embedding social workers to look through our 911 calls to follow up on the suicide threat calls has been very successful. You know, really what it is, you know, breaking down the silos and pulling everybody together so that our efforts are coordinated, and that you don't have one group working one angle, another angle. So it's that leadership and coordination that is important, in adapting our organization so that we can help people to the best of our abilities, and that involves that close collaboration.
I love that. I like that phrase of breaking down the silos, and the way that you're working to with your partners to kind of build out those continuum of supports and respond to what you're seeing as some of these needs that could be responded to in partnership with health and social service staff, or that you may be able to have them respond to as well. So thank you for that that perspective. I'd like to build in another component of this conversation. And Dr. Peinholz, I'd like to bring you up to help kick that off, which is, you know, over the past couple of years, the racial disparities in the impact of the COVID-19 pandemic and the increased focus on racial inequities within law enforcement and the criminal justice system have both called attention to racial justice in different ways. So as people work to build these more comprehensive and effective crisis systems that you and our other speakers are outlining, how do they ensure that they are building systems that are more equitable and just as well?
Yeah, that is such a great point and a great conversation to be having. Unfortunately, the conversation has been heightened by tragedy, but sometimes in honor of the tragic outcome, we can honor it more by doing better and fixing things. And it's not just the morally right thing to do, it's an imperative for us. We have to look at inequities, and there is a major overlap of inequities between healthcare and the justice system, and there's structural issues, stigma, discrimination. And if you overlay the issues for people with serious mental illness and intellectual and developmental disabilities and other types of factors, you get a huge swath of converging variables. I mean, we know that people with serious mental illness die 20 years earlier than people without serious mental illness. If you add to that people with trauma and justice histories, you have, and you know, look at our opioid overdose rates, you have many factors that really are apparent, and COVID-19 brought that out even more. So some of the things that we have to do is really just intentionally look at our data and look at our outcomes across different populations. We have to look at the social determinants of health. We know that poverty, exposure to stress and trauma, poor environmental conditions, lack of access to quality food really makes a difference. I was recently interviewing somebody in a community who was a community outreach worker, and he says, if you grow up in an environment that looks like trash, you're going to feel like trash. The self-esteem issues are huge, and what that does, we know that kind of pervasive trauma of feeling unequal or less than can create mental health challenges for those individuals. And so we have to be intentional about how we address this. And in the crisis space is a place where we have to be intentional about that too. Because what happens is when somebody faces a crisis, if they don't trust the system, they're not going to reach out for help necessarily, and things will just escalate. And so we have to think about how we build out our crisis continuum of care in a way that's effective, but also equitable. We talk about accessible, just, equitable kind of responses. So, the phrase that the Health and Human Services is using is that these services have to be adept for anyone, anywhere, at any time. And the anyone is really broad, so that anyone who needs help can get that help and feel like it's a system that responds to their needs. There's always going to be certain populations that are going to have unique needs. And so how do we build in cultural competence, trauma-informed responses, thinking about diversity within the communities, bringing in representatives of those communities, having an expanded workforce that understands different communities and different individualized needs, bringing in experts, for example, who may be able to be knowledgeable about particular communities so that we can really inform our thinking related to how a community response can best meet the needs with humility, the concept of cultural humility, and recognizing that I don't know what another culture might need, but I can hear that voice of somebody from that culture or from that population and better respond to their needs in that way. And so that cuts across, I think, the law enforcement response, the behavioral health response, the healthcare response, really looking at the individual needs. There's going to be intersectionality across needs, being a woman of color who's also from a Native population. I mean, there's lots of different things that we can think about. And so really understanding from an individualized perspective how to meet those needs. And it's a tall order. We have to train the workforce. We have to be cognizant. We have to hear the voices of people with lived experience who can inform our thinking about how to best meet the needs of those responses. So even though, I'm trained in this biopsychosocial approach, we have to really think about that biopsychosocial approach in a much broader way to meet the needs of individual communities. So data, training, cultural humility, competence, all of those things are going to be ways that we're going to continue to build this out in a better, so that we're more responsive to the unique needs of populations.
Thank you. Taking that biopsychosocial approach and broadening it to think about how you meet everyone's needs, I think is a really important point. And I think what you're getting at is this idea that if you really design systems for people who sometimes a system just has not worked for in the past, that it works well for everyone. So I really love that, Dr. Pinels. Thank you so much. And I think, Mr. Shirls, I'd like to bring you up because I think that you can respond to that based on the work that you're doing in Newark. And so, from the perspective of someone who runs community-based health, social service programs, have you approached addressing racial equity within that work and ensuring that the Newark community that you serve, which is largely made up of people of color, has access to behavioral health and crisis care? And Mr. Charles, I think you're still muted.
All right, here we go. Thank you so much. And, thanks CSG for the opportunity to talk about the great work that's happening in the city of Newark, but also that's happening in multiple cities across the country in terms of these comprehensive complementary strategies to public safety that are being led by impacted people. And so just to give a little context, I, grew up in one of those impacted communities. Grew up in the Jordan housing projects in Watts, and as a young person, participated in youth violence, and in my early 20s was instrumental in organizing a peace treaty that changed the quality of life in our community. Right, our strategy was then adapted by the city, and created like multiple consecutive years of reductions in overall violence and crime in the city, because impacted people were actually hired, trained, and deployed as public safety professionals in these respective communities. In 2014, I was tapped by the mayor Mayor Ras J. Baraka in the city of Newark to build out his community-based public safety initiative, the Newark Community Street Team. And since our inception, we have this multi-pronged strategy in which we hire residents from the community. We train them in high-risk intervention, in assertive outreach work, and in victims advocacy to address incidents of violence, both long-term conflict as well as present conflicts, and have been highly successful as a part of a coordinated strategy in terms of creating an ecosystem of safety. I mean, when we started our work in Newark, we had over 103 murders in the city. And 2019, we had a 60-year low during the spike in the pandemic during 2020. We still had only, we cut the homicide rate in half. And in the South Ward, where our work has been targeted, we had a negative 48% reductions in homicide because of this coordinated strategy, right? And so our work, has been celebrated, as a place-based strategy in multiple cities across the country. And all of this work is actually being performed by residents. 98% of the folks that we hire are residents of the neighborhoods in which they serve. We train them in conflict resolution, mediation, de-escalation strategies. We work through a trauma-informed lens. And we also understand that violence is a public health issue. And those who are closest in proximity, right, to the problem should be equipped with the skills, the tools, and the resources to do the intervention, the prevention, and the treatment. And so, most recently, we just launched an overdose response project, working in Newark, which is really kind of like an extension of the public safety work that we've been doing, through this public health lens. And there is less of a distinction actually between our current violence intervention strategy and the overdose response work that we're planning, now. We've consulted with my brother Black here, in cahoots on helping us to inform the approach. But the individuals that we are currently serving and those who we will be serving are all a part of the same community. Black and brown impacted people. We work through this racial justice lens. They're all struggling with the same symptoms of poverty, racism, and historic underinvestment that has produced high levels of traumatic stress, hypervigilance, and vicarious trauma. At the core component of both our public safety and public health approach is hiring staff that live in the neighborhoods where we're serving. And that is one of the core of our approach, right? And that we train them in conflict resolution and CPR and motivational interviewing, and that all of our services are trauma informed, right? This is a key, to any community responder model, is that those who are closest in proximity to the issue be given the resources to approach the solution. Another core component and value of both our public safety and public health model is that our work is rooted in understanding harm reduction, right? That drugs, is in Newark has the highest percentage of overdoses in the state of New Jersey. And 90% of those who are having the overdose are Black men, right? And so we got to understand that drug use is complex, it's multifaceted, phenomena that encompasses a continuum of behaviors from severe use to total abstinence. This idea of harm reduction, and that it acknowledges that some ways that folks are kind of like self-medicating because they don't have access, and resources to real comprehensive services. And so our work is about reducing harm, whether it's violence or whether it's drug addiction, for individuals, families, and communities, because there's a ripple impact, right? While also trying to reduce just issues across the board, because it impacts the whole system, right? Our overdose response model was developed by a group of stakeholders that included, the Newark Police Department, our local EMS, service providers, community-based organizations. We engaged over 400 individuals in the community in a survey, and we asked them kind of key questions, and we discovered that that very few people even knew about harm reduction. That a lot of folks, even though there's a good Samaritan law in place, still would prefer to have a social worker or a community outreach worker to respond. And that one of the biggest issues that we face, right, is housing, whether it be emergency relocation or just for places for people to live equitably, right? And so we now are presented. We just finished actually our proposal, and we presented it to the city. And now we have this this model that we're proposing that includes outreach workers partnering with EMS, through 911, because currently our high-risk intervention team that does our public safety work is on the police dispatch. So if there's a shooting or a shooting hit, the high-risk intervention team responds to the scene, never crossing the yellow line, but talking to the victims and survivors on the other side, following them to the hospital, connecting with our community health workers who are engaged, who are embedded in the hospital as a part of HVIP, the Hospital-Based Violence Intervention Program, and develop safety plans, right? Because here's the thing, we know that there's a pretty high threshold in terms of arrest and prosecution, right? And so law enforcement is not always able to make an arrest because sometimes they don't have enough evidence in order to do that. And so they depend on these high-risk interventionists or credible messengers in the community to intervene and develop safety plans to prevent retaliation and deal with rumor control until they can actually develop enough evidence to make an arrest. And then even after that, having a person go to jail doesn't always solve the problem as well, right? We know that it requires an ecosystem. I was shared earlier. It requires an ecosystem of services to actually address harm in communities. And so our community responder model will have outreach workers and EMS responding to 911 with law enforcement as that secondary support, because this is what the data has told us through the survey that we did in the community, and that we want to make sure that we're educating the community about these services and where they're located, and so it's this work is really comprehensive. It's challenging, but we're excited about the early promises that it's shown already through our public safety and public health model. And so we believe that through this behavioral health model, we'll have a similar impact on being able to reduce the incidence of OD in the community.
Thank you, Mr. Charles. I think that's helpful to hear both how you're taking some of the lessons that you've learned from the violence intervention work and applying it in a public health space so that your community responder program is going to be supporting people in substance use crisis and people who are experiencing an overdose, and really taking some lessons that you've developed around how you employ people from the community that they're going to serve as a way of both ensuring that people have access to care and are willing to connect with the people who are sent out, but also it sounds to me a little bit like as you mentioned, sort of a racial justice approach and an economic justice approach, because you are reinvesting resources in the community that you're serving. I mean, does that feel like a reasonable summary of how you're thinking about this building out of the work that you're doing?
Absolutely. I mean, that is exactly the approach. I mean, if we don't invest in the very people, as the solution bringers, as I said, through the public health model, the public health frame says that those who are closest in proximity to the issue should have the resources, the skills and the tools to be able to do the intervention, prevention, and the treatment. And so in most cases, those are impacted people. And so we want to invest in that model. And of course, there's workforce development training stuff that has to happen, because people are highly traumatized in these neighborhoods, and that, it's a part of the overall work that has to be done in order to advance safety in our community.
Thank you, Mr. Charles. I think that that's really helpful to hear your thinking about that, and also, touching on what I know Dr. Pinels mentioned about the need to kind of build up a workforce who can support everyone who's in need of crisis services, and the way you're doing some of that on the ground. I actually want to skip around a little bit. If I could, Mr. Black, I know that, Mr. Charles just talked a little bit about how they're thinking about which types of calls that they're going to respond to. But from the perspective, Mr. Black, for you of a community responder program, how was it, or how does Cahoots determine which calls are appropriate to respond to?
Yeah, the intention around our program is really to provide that alternative to law enforcement or traditional response for these issues that really need a different kind of first responder. And so it really started by looking at where we could make the most impact. And in the late 80s, that was specifically around mental health and homelessness. As our community grew and as new needs emerged, we would find opportunities to come back to the drawing board and talk to our partners in public safety and say, look, there's this new pocket where we're seeing emerging need, and we think that we can have a really positive impact. We see that officers are really being burdened with these responses. So let us take on a little bit more of that work. Allow us to really support everybody in this system, focusing on doing, I guess a smaller subset of duties really well. So one of those areas was around grief and loss, and having Cahoots teams come in and do those death notifications instead of obligating officers, because that was a big demand on their time. Those are lengthy interactions. As we started to see more and more need for medical response around addiction, that was a time for us to talk with our partners in public safety about how we can utilize those medics that we have on the vans to respond to more and more of these situations without relying on an ambulance to, kind of get out there at 3 or 4 in the morning. So, it's really about responding to community need. And the way that we do that is by staying connected, by having a council of folks that can hold us accountable, that can help us maintain that transparency, and can really let us know, when there is that emerging need that we could have a role in addressing.
Thank you so much, Mr. Black. And, I'd like to also hear that's kind of a similar question, but from a law enforcement perspective. So if I could bring up Chief Ramsey, I think reacting to what Mr. Black just said, but also what you said in your previous comments, you kind of raised the idea that there might be some calls where law enforcement should go out, as you do now, with behavioral health or social service staff, but there also might be calls where law enforcement might not need to go. So how do you as a law enforcement leader think about which calls do need a law enforcement response, which could use a co-response model, and which ones could be responded to by other health or social service staff? What are the considerations that you kind of go through when you're making those decisions?
Yeah, every city is so different. I've worked in rural, suburban, mid-sized city and large city, and they're all vastly different. A lot of it depends on, our poorer communities are disproportionately impacted by lack of resources for mental health. So I can tell you that about 20 years ago, we did a project where we called out deferred calls to social workers to respond for crisis-related calls. And after about 7, 8 o'clock, we found that, and it was a team of 8 women, that we found they didn't like to go without police there if it was at a home or in certain, without other resources there. So every city is very different. And so this the multiple effort teams that we're building with the family caseworkers, the embedded social workers, we've also built a group of interns that assist us, the housing stabilization caseworkers, all those various partners fill different gaps that we have. But we do get concerned that oftentimes around and our biggest issues are those that are violent individuals that are suffering violent tendencies, that police have to be involved. There are just, there's danger considerations that we have to take into account. So from our perspective, it is kind of a moving, evolving program at how we're working it. But I can tell you that our integrated care team, the paramedics, the social workers really like that police officer there with them. That's probably the model that for field response has been most widely accepted and people feel comfortable with.
Thank you, Chief. I want to say that I feel like we're obviously hearing this kind of theme of collaboration and figuring out where everyone's kind of role is in their space. And I think one of the tensions that we're having in this current moment of reform really as people are aiming to build out crisis system responses that rely less heavily on law enforcement, is how much those community-based responses really coordinate with law enforcement. And so, first I'd like to bring up Mr. Sherrills, because I think you've done some work, of course, to think about what coordination with law enforcement looks like, as well, while also being able to serve the community. But then I think I also want to talk to Dr. Peinels and Mr. Black about some of their experience here. But Mr. Sherrills, could I talk to you a little bit about that, or get your sense about that tension and how you navigate it?
Absolutely. The Newark Community Street Team is in CVI work, community violence intervention work, is essentially a complementary strategy to policing. They're parallel tracks. CVI work doesn't traditionally share intelligence with law enforcement, right? Because it could potentially get, those credible messengers. You lose your credibility and ability to be able to navigate some of the conflicts that happen in the neighborhood. And we still live in very violent communities, so you could also potentially lose your life, right? And I think that our law enforcement partners now, they really understand that. It took us a few years, speaking specifically about Newark, it took us a few years for us to kind of get the relationship tight. I think that, from the top, the public safety director, the chief, the brass, they understood this work conceptually and philosophically, and so they bought into the model. But it was actually getting patrol, and the shooting team or the homicide division to buy into this work, and that took a number of years. And this is just a natural process, because they wanted to be sure that these credible messengers that we hired, these are ex-gang members, ex-convicts, folks who were justice involved in the past. They paid their debt to society, and now they wanted to get back to something that they have caused harm to. Right? They wanted to make sure that these individuals weren't straddling the fence and that they were all in. And so when they discovered that we had a very extensive training process through the Professional Community Intervention Training Institute, that folks operated on standard operating procedures and protocols very much like them, when we met together in those monthly meetings and those biannual meetings, and they saw us demonstrate that our knowledge of public safety and public safety protocol, people started to put their guards down. And then when they saw how we demonstrated in the field in terms of responding to shooting hits, that we didn't cross a yellow line, that we engaged the residents on the outside, that we connected them to victim services, that we knew things about supporting survivors of violence, that was a little bit out of their jurisdiction, because, our officers have a huge job, right? And then they don't always get all of the support that they need, right, in terms of doing this work. The vicarious trauma and hypervigilance that our officers experience sometimes, doesn't allow them to come to work kind of fully grounded in their own humanity because of what they have to witness on a daily basis. And we also know that, sometimes within policing, they don't get the proper counseling and therapy and healing modality necessary so that they could, show up in this work, because it could be a stigma within the department sometimes that can get you rubber gunned and desk, and it's a reality. And so when our team got an opportunity to sit and go through those trainings with officers and hear about how they're working on 25 cases, and they have a small team, that's doing an investigation. And I mean, one of our guys came up to me and was like, man, he said, I can't believe this, because traditionally folks there's this divide between community and law enforcement, right? And said, I have a tremendous amount of compassion for the cops, man. He said, I didn't know the type of pressure that they're under in terms of this work. And I think that also on the other side of it is that when they saw that our folks had intelligence, in terms of being able to step into the field, mediate conflicts to peaceful resolve where arrests, couldn't be made. Today, our partnership with NPD is one that they call us and give us intelligence about things that are happening in the field, because they don't have enough evidence in order to make an arrest, but they might know who the shooters was. And so it gives us an opportunity to leverage our relationships on the ground, to do a lot of the maintenance work, and we document all of this as well. So this work is evidence-based and it's anecdotally based. So it's not just we're out there kind of bumping heads. And so it's created such a powerful partnership that we've had 6 consecutive years in a row of decreases in homicide and overall violence. And so, and there are multiple like kind of initiatives, you know, Cure Violence Global, the National Network for Safe Communities. And you know, it's one of the things that I'm most proud of, honestly, because, you know, the Biden-Harris administration has now invested a significant amount of resources into CVI work with the White House, you know, Community Violence Intervention Collaborative, you know, partnering with 4 of the top like national TTA providers to build capacity of CVI now to really be a complementary partner, you know, in terms of public safety in communities, because we now know that you know, public safety it requires an ecosystem of services, right? It has to be a shared strategy, and we can't advocate, the community can't advocate its responsibility and put it all on the cops, you know, and on our officers to have to resolve every issue that comes up. And I'll just make this final point that 60, like when we first started our work in Newark, we did a study with the Safer Newark Council, and this was the body that coordinated our public safety strategy in the city, and discovered that 62% of the homicides in the city started as domestic disputes. And so if we can train residents, right, and it starts as like, you know, the neighbors getting into it over snow removal, you know, the neighbors getting into it over, you know, trash cans, and these conflicts, and, you know, sometimes neighbors be in conflict for like 10, 15 years. And so if we train folks in conflict resolution, mediation, de-escalation strategies, right, we can step in, we can diffuse the bomb, you know, and we can create more equitable relationships in the community. And then we can have our law enforcement partners to focus on more serious, you know, crimes that are impacting the community. And so this is a strategic partnership. And I think that there's a lot of innovation, you know, that's actually developing in this work as well, that are creating much stronger relationships between community and law enforcement through this CVI like kind of frame.
Thank you, Mr. Schrills. And I think that, you know, hearing how you've been doing that within the violence intervention work and how you're sort of moving that kind of relationship into the overdose response space also brings to mind, you know, if I could, Mr. Black, I feel like when I talk to you, you often tell the anecdote about how the Cahoots name started. And so I'm wondering if you could speak a little bit about the coordination between Cahoots and law enforcement, how you also navigate that tension that's in the current debate about coordination between community-based programs and law enforcement, as well as to speak to some of what Chief Ramsey spoke about in terms of considerations around safety and which calls could be responded to. Can I ask you to comment on that, Mr. Black?
Yeah. One of the areas where, you know, we've seen a lot of opportunity in our collaboration with law enforcement is understanding that we have unique and complementary roles, and that we have a shared mission of supporting each other in doing those primary roles really well. So that takes the form of, you know, really being open to conversation, you know, meeting regularly and building relationships, you know, with not just the chief of police, but with patrol officers, right, with dispatch, spending time in fire stations, and really just getting to know the rest of our public safety system. You know, we also extend that by showing up and really being there, and recognizing that there are times where the person that we're supporting the most may actually be the other responders in that system. You know, and with the you know, I guess social unrest and everything that we experienced last summer, you know, that definitely did put a strain on the relationship that White Bird Clinic and the Cahoots program had with law enforcement. But what we were able to come back to at the end of the day was that we really both shared this goal of providing the right kind of response to our community members. And yes, there are always going to be the potential for, you know, personal or political disagreements between individual responders on Cahoots and, you know, officers within the police department or paramedics in the fire department. But you know, we still can find those things that we share, and that's really about, you know, serving the community and really, like I said, just providing the right kind of response. And part of that really is tied into our ability to keep our responders safe out in the field. One of the understandings that we have is that as long as it's just Cahoots that's talking to somebody out in the community, that interaction is going to remain entirely voluntary. Cahoots teams don't have the ability to place a hold on someone to take them against their will to the hospital. You know, we can't force somebody into a civil commitment process. But what we can do is really provide an opportunity to find some sort of stability that doesn't require those, kind of traditional higher levels of care. And so our community knows that when it's just cahoots, there's not that risk of being taken to the hospital, against their will. And that's one component of what keeps us safe. We extend that by really making sure that community members in crisis can really tell that this is a different kind of response before we've even engaged with them. By wearing a t-shirt and hoodie, some jeans, by not having a bunch of other equipment on our belts, we send a visual message that this isn't going to be a law enforcement interaction. And for those in our community who have had those really adverse experiences, this is a way to kind of get through that crisis, to kind of get through the amygdala hijack, that lizard brain fight or flight, and say, okay, this is going to be a different kind of interaction. But before we've even gotten out there into the field to talk to somebody, we really need to make sure that we have good communication with dispatch, that we are really working together in ways that allow that screening process, that triage, to help determine when there are situations that might not be safe for cahoots responders, and then work with us and other components of more traditional systems in our community to still find a way to provide the kind of response that that person in crisis really deserves and really needs.
Thank you so much. And just before we turn to some of the audience question and answer, Dr. Pinels, I want to give you a chance to comment on this kind of theme of coordination across systems and navigating some of that tension, but also sort of the benefits of bringing everyone in the room together. So as you have mentioned, when we've spoken before, many communities are building stakeholder coalitions at the local level to help improve crisis services. How are you seeing communities build those, and how are you particularly seeing them build in perspectives that aren't just, say, traditional behavioral health stakeholders, but also partners that are often overlooked, people with developmental disabilities, community members, families, youth, others, all together in one room? Could you speak to that?
Yeah, I mean, I think it was so interesting to hear Mr. Shirelles and Mr. Black speaking, because I think they're giving examples of totally different communities and totally different ways that they have brought partnerships to the table. And what I'm seeing, in Michigan and around the country is that some of these other partners weren't necessarily even brought in with the behavioral health system. And so now, through some of the conversations, partly inspired by 988, partly inspired by some of the federal work, both at SAMHSA and BJA, DOJ, all of this is kind of coming together. And so we've got the behavioral health leaders looking at who do they need to bring into the conversation. And suddenly EMS, I can speak for myself. I work really closely with our medical director of the Bureau of Emergency and Trauma Preparedness as a psychiatrist medical director. So we have partnerships that didn't exist in other ways before. And so you see that there's this kind of snowball effect of who the partners need to be. Suddenly you're like, oh, I got to bring in the folks that represent developmental disabilities. I got to bring in folks that represent, communities of color, faith-based organizations. Everybody needs to have a seat at the table around how these crisis responses are going to work for their community. No two communities are alike. I'm thinking about rural communities up in, where we have up in the Upper Peninsula compared to when I worked, in Massachusetts, and you think about the Boston community. Very different needs, very different models of how you're going to come together and bring people together. But I think the idea is being open to partners and what we would consider, what each entity might consider a non-traditional partner. And that's, I think, part of the framework that we talked about even when we, in 2017, when we started talking about this vital continuum of care, is this building out non-traditional partnerships. And it's even more so true in the crisis continuum.
Thank you so much, Dr. Pinels, and thank you all. What I'd like to do now is just turn to and try to get to as many of the audience question and answer that we can. So if I could bring everyone back up on the virtual stage, thank you so much. Just looking through some of these questions. The first one, it looks like, if I could turn to you, Mr. Black, we have a question from the audience. For cahoots, can you tell us how the initial calls for service are triaged at the PSAP? and how the risk assessment is done to determine whether or not a law enforcement response is required. Are you able to speak to that?
Yeah, when the calls are coming into our public safety answering point, regardless of what, somebody pushes for that prompt, 1 for police, 2 for fire, 3 for Cahoots, all of those calls are being screened to really determine what's the most appropriate response. And I think we have to recognize that we do have a lot of privilege in the fact that there are 2nd and 3rd generation public safety professionals in our community who have never known what a public safety system looks like without these kind of Cahoots services. So I just want to put it out there that I recognize there's a lot of privilege that comes with that. But all of those calls for service are really being triaged to determine what's the most emergent needs, and what is the right response to address that priority for the individual. Somebody might call in and say, for instance, I remember there was somebody who called in because they needed to get Bill Clinton out of their attic. Now, it was highly unlikely that Bill Clinton was in that attic, right? And so the fire department probably isn't who needs to be out there. Police probably aren't needed for criminal trespass, but Cahoots can come out and talk to that person about the fear and anxiety and the paranoia that they're feeling and really, address some of those other underlying issues. But the caller didn't ask for Cahoots, so it's those call takers that are really in that position of determining what it is that's needed and how that need can be addressed, with whatever limited resources they have. When there are situations that are kind of outside of the more traditional set of Cahoots responses, there's opportunity to engage with us, to talk with Watch Command and say, look, we've got this really unusual circumstance. I think Cahoots could do this, but it also seems like there's a role for patrol to play. And because we're all humans, right, we have that opportunity to be creative and look at what multi-systems response could mean. That even takes the form of, more public mass casualty or, for instance, if there's some sort of traumatic event involving traffic, having Cahoots come out and respond to support witnesses who are having some initial trauma from that experience while officers engage in their investigation and paramedics are addressing other medical emergencies. There are a lot of ways for us to really work together, but it all starts by, by having those clear lines of communication and by having members of that PSAP system who are really open to that collaboration and willing to find ways to get us in when we're needed.
Thank you so much. And we have a lot of questions rolling in. I'm going to try to get to as many as I can. One question, and if I could ask everyone to try to do their best to do just a short response, because I want to get to a few of these. But for you, Mr. Sherrills, we have a question. Did you face any struggles in hiring from the community to staff your positions, and was it difficult to find qualified people or people that wanted the positions?
It wasn't difficult to hire people, to find qualified people, to do the work. The challenge became in retention, because, these individuals might have like significant relationships and know all of the folks in the neighborhood, but just in terms of the level of trauma that folks bring to this particular work. I mean, as an agency, we like to think of ourselves as not having like kind of a corporate culture, but we have a corporate infrastructure, right? We have graduated disciplinary processes and stuff, right? We do terminate people and stuff, but we had to essentially bring in like kind of real trauma support and self-care systems to support our staff. In addition, we had to build out a workforce development system based upon transformational education and andragogy so that we could tap the lived experience of folks so that they could have the greatest impact in terms of this work. So not hard to find folks. Training and retention, are the challenges.
Thank you. And, this last question, I'm going to edit it as I'm reading it, but it really is getting a question out. There's a few that are like this, asking about, it's really important to improve the point of response, but also really thinking about that continuum of care for people after they're in crisis and the need to provide after crisis intervention services and what are some of the innovations or needs in that space. So I'm wondering maybe Dr. Peinels, if you could take that question as part of thinking about what's important to support people with behavioral health and other needs.
Yeah, I think there's a lot of things going on around the country that are pretty cool. You can't, as we roll out crisis services, the question is always going to be what next? What happens after the crisis is resolved? Some communities and states are baking in this, a lot of this is in youth mobile crisis, aftercare follow-up in the home for a period of time that gets funded through the behavioral health system, as an example. Others are building out crisis stabilization unit, or what's becoming known as crisis hubs, where people can go and then be triaged or directed into the next level of care, which ranges anything from outpatient to inpatient if it's a psychiatric emergency or a substance use need. You can also have urgent care centers. Everybody goes around their block and there's an urgent care center. Get your throat, if you have a sore throat, you can get it checked, or your COVID test or whatever. We need that for mental health and behavioral health as well. And then we need all of these linked to other types of supports, as Mr. Sherrill said, things like housing supports, nutrition supports. We have to look beyond just the psychiatric behavioral health system or the substance use system to other things that are driving crisis, the social determinants, and really getting upstream and getting people the nutrition, the housing, whatever other supports they need, and bake those into that continuum. So it's not just a continuum of care, it's a continuum of support. So there's some great innovations going on, and I think there's more to build out.
Thank you so much. Thank you all. I really just, there's tons more questions that we won't be able to get to today, but we will do our best to try to respond if we can offline. And so first, I just want to say thank you to all of our panelists and all of our amazing speakers. This is the kind of rich discussion that will continue throughout today and tomorrow. I encourage you to attend the breakouts. These sessions will dig deep into a range of important topics, such as triaging 911 calls, involving people with lived experience in designing and operating crisis services, how communities are advancing racial justice and health equity, and many more thoughtful conversations. To select your breakout, you just click on the link below for the session you're most interested in. If you're in full screen mode, you'll need to exit that view to see the breakout session options. And definitely make sure to join us for tomorrow's plenary. In recent years, the federal government has made unprecedented investments in supporting crisis services. And tomorrow at 12 noon Eastern Standard Time, our panelists will discuss how federal resources can be used to support the development of robust crisis systems. We'll hear from representatives from the Department of Justice, Health and Human Services, Housing and Urban Development, with tips about how to access those funding and technical assistance resources. And then following that conversation, we will have another fantastic set of breakouts, which you can see in the conference schedule, which is linked on your screen and also on the conference website. So just thank you again, and please enjoy the rest of the day.